Yeah, Dr. Shankar.
Yes, visible, sir.
Yes, sir.
Everything. This video is. देखता हूँ चल रहे हैं कि नहीं. Just let me see the videos coming up. Because we have 3-4 minutes. So conditioning why I don't know this video. You know, this is an unusual situation. My laptop has never, you know. ये टन टन की बात क्यों आ रही है? Is this moving? Heart is moving. Can you see it?
Yes, sir. Moving.
Yeah. Let me see. Just go to another video. Then we will start. Huh? Is this? Can you see this video playing?
Yes, sir.
Yes, sir.
Okay. Now everything is fine. Now I go to my first slide now. Huh? Okay.
All right.
It's so we have started with sweating now. Huh? Let the screen be okay. It's fine.
Yes,
Stop.
sir.
If you want.
Or you want me to escape?
You can underscore your screen. That will help. But if it will be difficult to go back again, then I think it's okay that we keep it.
So we are about 1 minute to go. It's 6:59. Is it? जितेंद्र जी प्रोग्राम अभी लाइव तो नहीं हो रहा ना?
Is coming, sir, within 2-3 minutes, sir. Then we'll start, sir.
Okay, okay. So as of now, it's not live.
No, sir. No, not yet, sir.
Okay, okay. That's
When it is live, it is visible to every delegate, but it is not recording right now.
okay.
There are around 120 people who are joining.
Yeah, I can see that 118 now.
Let me know when to start.
يمكن تصديق
Zoom. I got his hours.
Yeah. Hi, Dr. Vinita. Are
Yeah.
we starting? 7:03.
Yeah, we're just waiting for signal from Jiten that we can start.
Sorry, your voice is breaking.
I'm just waiting for Jiten to give the green signal when to start. Hello,
Yeah.
can you hear me?
Yeah, I can hear you now. Yes.
So we're just waiting for him to give me the start.
Okay. Jitendra,
Yes, ma'am.
it's 7:03. Shouldn't start?
Yes, ma'am. You can start from Dr. Vinita, ma'am. Dr. Sibbal sir is joining. He'll join in between.
I wait for him, right?
Yeah, we should
I'm
wait for
very
him.
much there. Please start. I've been there for several minutes, Jitendra. Please
Okay.
start.
Hi, sir. How are you, sir? Good evening,
Hi,
sir.
Sid.
Please start.
Hello, everyone. Greetings of the day, wherever you are,
Recording in progress.
whichever part of the world you are in. Welcome to the first session of GAPIO International Lecture Series. Let me introduce myself briefly. I'm Dr. Vinita Sharan. I'm an advisor for radiology CMEs for Global Association of Physicians of Indian Origin, GAPIO. I'm a radiologist with fellowship trainings in breast imaging, ultrasound, and CT and MRI from Makati Medical Center, Philippines. I have over 16 years of teaching experience as associate professor at San Beda College of Medicine, Manila. I have worked as a teleradiologist and created digital knowledge products for emergency radiologists for reducing reporting turnaround time. Apart from my diagnostic and academic work, I have done advocacy for mammography as tool for early detection of breast cancer. I have a master's degree in public health from London School of Hygiene and Tropical Medicine, University of London. And recently I have moved back and settled down in India. Today I will be moderating this session. So today is a special day as GAPIO embarks on a partnership journey with Global Association of Radiological Technologists of Indian Origin, GARTIO, which is an umbrella organization of Indian Society of Radiographers and Radiological Technologists, ISRT. We plan to have regular teaching sessions on different imaging modalities and various body parts in the future. The goal of these sessions is raising the technical skill of radiological technologists of Indian origin residing in India and abroad to match international standards. It also aims at raising awareness on various radiological procedures among physicians of Indian origin globally. In today's session, we will be learning about MRI as imaging tool for cardiac diseases. To open the session, we have the president of GAPIO, Dr. Anupam Sibal. Dr. Sibal is the group medical director of Apollo Hospitals Group since 2005. He has been the president of GAPIO since January 2020. Dr. Sibal is a member of Regional Middle East International Advisory Board of Joint Commission International, JCI, since 2011. He was member of Institute of Body of PGI-MER, Chandigarh, from 2009 to 2014. He is honorary clinical professor at Macquarie University, Sydney, Australia. Among his major achievements is setting up the first successful liver transplant program in India in 1998 at Apollo Hospitals. The Apollo transplant program is the busiest solid organ transplant program in the world since 2012. 4,005 liver transplants have been performed so far, of which 458 were pediatric cases. He has 124 publications and 15 chapters in his name. He has given more than 401 national and international lectures. Dr. Sibal has edited a textbook in pediatric gastroenterology and hepatology and nutrition published in 2015. He is author of the national bestseller, Is Your Child Ready to Face the World? I now invite Dr. Anupam Sibal to give the opening remarks.
Namaste, good evening, good afternoon, good morning, because we have colleagues joining from different parts of the world. And if you have anyone from Australia or New Zealand, it's really late at night. So thank you so much for being a part of this program. For those who don't know much about GAPIO, GAPIO was established 11 years ago with the aim to bring together 1.4 million physicians of Indian origin on one platform. We now have members from 57 countries, and we're delighted today to be partnering with the Global Association of Radiological Technologists of Indian origin, a body that was set up as recently as 15th August 2022. Been very impressed with what the Indian Society of Radiographers and Technologists has been doing over the years. It's part of a program that was organized recently, and I think the energy, the enthusiasm, the spirit with which the team works is commendable, and it was so heartening to see that there are clubs and branches across different states, and now that the organization has decided to go global, it will get bigger and we'll be able to sort of engage with the Indian diaspora across. And we are so delighted that GARTIO is going to be a part of our annual global conference in Gandhinagar next month, and we would be delighted to welcome you all. Today, we have this very interesting session on MRI as an imaging tool for cardiac diseases. And we have very eminent faculty. We have Professor Paneer Selvam, Professor Singhal, we have Ms. Azhar, we have Nidhi, we have Suresh, and of course, Vinita ji, who's anchoring this and moderating this. A big thank you, Vinita, for organizing this. Really nice the way you conduct these sessions. And of course, we have Vinita. And of course, a big thank you to Dr. Sushil Jain and Jitinder Malik for their support. With those opening comments, I wish this program all the best, and I'm sure it's going to be very useful, and we look forward to running several such programs. So over to you, Vinita ji.
Thank you so much, Dr. Sibal, for your opening remarks. Now we have Professor Paneer Selvam, who is the chairman of Advisory Council of GARTIO. Dr. Selvam has done his postgraduate degree in medical physics from Anna University, Chennai. He has 36 years of teaching experience and is currently Associate Professor of Medical Physics at Sri Ramchandra Institute of Higher Education and Research, Porur, Chennai. He has 5 publications and has given more than 575 guest lectures. He has received Professor Kakala Subbarao Lifetime Achievement Award, Dr. V.P. Narayanan Lifetime Achievement Award, and Professor C. Retina Sapati Endowment Oration. Professor Selvam has an interest in MRI, digital imaging, and mammography. He is faculty for MD DNB, FRCR Part 1, BSc and MSc in Medical Imaging Technology. He has been involved in quality assurance and safety program for JCIA and NABH accreditation process. I now invite Professor Paneerselvam to give the opening remarks.
Thank you, madam. Thank you. Respected dignitaries in this online program, dear faculties, senior members of GAPIO and GARTIO, very good evening to all of you. It's indeed a great pleasure and honor for me to be a part of this historical event of first GAPIO and GARTIO combined CME program. It's matter of pride for all of us from GARTIO that we got associated with GAPIO for the professional development. Would like to highlight few things about GARTIO. Radiological technologists are the the main pillar of allied health professions and play a vital role in incorporating the technological innovation with the clinical medicine. Radiological technologists from India are working in various places of the globe with high academic and professional background. This GARTIO is the brainchild of our ISRT General Secretary, Mr. Suresh Malayat. The main objective of this to bring together the various radiological technologies of Indian origin distributed throughout the globe and to promote the education, practical training and research, to develop the professional network and to promote academic activities, particularly for knowledge sharing and cultural relation, and welfare of Indian origin technologies by ensuring the better career opportunity. That's also another objective. With these few words, I would like to congratulate and wish that this first online program event will be a successful one and create a pathway for a long association of GARTIO with the prestigious GAPIO. Thank you, each one of you, for this wonderful and memorable opportunity. Wish you the best. Thank you, madam. Thank you.
Thank you for the opening remarks, Professor Selvam. So now we go towards the session. Cardiovascular diseases are leading cause of death globally. Of these, around 3/4 of cardiovascular deaths occur in the low and middle income countries. Like any other disease, prevention, early diagnosis, and treatment is the key to decreasing morbidity and mortality due to cardiovascular diseases. Imaging has played a critical role in diagnosis of cardiovascular diseases. Conventional angiography, echocardiography, nuclear testing, computed tomography, and magnetic resonance imaging have their unique place in diagnosis of cardiovascular diseases. Continuous innovative research has given us new technologies and modified old techniques to make them cost efficient. Exploration in the field of cardiac diseases has shown MRI to play a significant role in diagnosing cardiac diseases. Today, we have a panel of distinguished speakers who will enlighten us on principles and protocols of cardiac MRI, challenges and solutions in cardiac imaging, and MRI as a tool in diagnosing cardiac diseases. To chair this session, we have Dr. Vanita Arora. Dr. Vanita Arora is a senior consultant, electrophysiologist, and interventional cardiologist at Indraprasth Apollo Hospital, Delhi. Dr. Arora is the first female electrophysiologist of India. She has received her fellowship training in cardiac electrophysiology and complex arrhythmias at St. Luke's Hospital, Milwaukee, USA, and cardiac resynchronization therapy at University Hospital, Magdeburg, Germany. Dr. Arora has been actively participating in national and international research trials for cardiac devices, drugs, electrophysiology as the principal investigator. Dr. Vanita is pioneer in the country for 3D mapping for complex arrhythmias, leadless pacemaker, cardiac synchronization therapy, and his and left bundle pacing. He has performed more than 300 radio frequency ablations, 3,500 permanent pacemaker implantation, 2,000 biventricular pacemaker, 500 mapping RFA for complex arrhythmias, and more than 120 leadless pacemaker implants. She has presented over 300 papers in national and international conferences and contributed to more than 100 publications in national and international domain. Dr. Vanitha has been awarded as Healthcare Personality Rising Star Woman Entrepreneur Awards in 2016, 2017, and 2018 by Times Healthcare, IMA NDB, and Business World Healthcare. He has also received Distinguished Service Award bestowed upon by His Excellency Dr. APJ Abdul Kalam for outstanding contribution in the field of clinical and preventive cardiology. Currently, she is Vice President of Indian Heart Rhythm Society for the years 2022 to 2024. She is past President IMA New Delhi branch and President of Indian Society of Electrocardiology. So apart from all these excellent achievements, she is also a trained Indian classical dancer and a classical singer. She has equal interest in sports as well. I now invite Dr. Vanitha Arora to say a few words and then invite our speakers for their talk.
Thank you, Dr. Vinita. This was a very elaborative and a kind introduction. I thank you for the kind words. And I would also want to thank you for making me the part of this eminent session, because as a cardiac electrophysiologist, the topics of this session today are very close to my heart. It is for the first time I'm participating in GAPIO and GARTIO. I'm new to this world, but it seems like a very interesting world, and I would like to be a part of it in the long term. As cardiac MRI, you have selected the topic of today. Cardiac MRI has become a very important part of cardiac electrophysiology. We deal with arrhythmias and cardiomyopathies every day. And whether it is to deal with arrhythmias, atrial fibrillation, ventricular tachycardias, frequent VPCs, we look at our cardiac MRI friends to give us more answers than what we already know from an ECG. That is in form of the definition of the scar in the heart and which areas are scarred and how much is the scar burden of the scar. So that gives us so much more confidence when we are going into the cath lab to do the ablations and makes our job easy. In addition to this, even for all patients of cardiomyopathy who are undergoing cardiac resynchronization therapy, cardiac MRI is the tool I go for, because where I have to place my LV lead, I mean, my good friends in radiology, they guide me with the definition and delineation of the scar, and it makes my job so easy. So over the last 10 years, I have seen a beautiful transformation in cardiac MRI imaging, and we have become, I would say, we are so well coordinated and correlated that we become best friends. We guide each other a lot. So having said those words, with all the excitement, I would like to invite the first speaker, who is Dr. Manful Singhal. Dr. Manful Singhal is a professor of radiodiagnosis and imaging at PGI Chandigarh. He has presented a lot of research papers in the international and national conferences, and has published about more than 130 publications and written 16 chapters in the book. He's also received RSNA and IRIA awards. So over to Dr. Manful Singhal to please take the first topic of today, which is cardiac MRI principle and protocols. Over to you, Dr. Manful.
Thank you, Dr. Vinita Sharan, and thanks, Dr. Vanitha Arora. And indeed, this is a wonderful platform that brings Indian diaspora on a single platform with a very good altruistic aim to spread the information cutting across the barriers, to create the uniform teaching standards, and to make the Indian diaspora nothing short of the best of the best. So the topic which is contemporary in nature, and we are going to speak on what are the principles and protocols in cardiac MR. As very well said, in the last 1 decade or so, the cardiac MR has gained a quantum leap technological advancements that has made the diseases which otherwise used to be enigmatic, alive, that we can have diagnosis. I say anti-mortem now, and definitely for electrophysiology, other things to quantify the scar, to delineate the scar, and to make sure that the leads are placed very well. So what makes cardiac MR so interesting, or put in other ways, why cardiac MR, took some time to be translated into the clinical medicine. We'll see as we move further. So what we are going to speak is why we are talking of cardiac MR. When we talk of principles in MR, so we'll talk of pulse sequences and imaging planes, because imaging planes, as classically taught in radiology, axial, coronal, and sagittal, heart doesn't, obey those rules. It has an oblique coronal position in the chest, so we have to create the planes which are akin to echocardiography, so that what we see, and what we interpret goes in the lines with the established norms, whether it's echocardiography or nuclear medicine. Then we talk of protocols. When we talk of cardiac MR, we talk of three things. We talk of cardiac structure, function, and tissue characterization. These are three things that we talk. So we will discuss the basic protocol that I say as late Gallium enhancement protocol, and then we'll see how it is protocolized as per the clinical needs. I will request all the people to mute themselves and switch off their videos, please. So this is, what I was talking of structure. When we talk of structure, we talk of black blood axial sequences, which are akin to the CT scans. And if so required, we can do bright blood coronal sequences that usually we do with congenital heart diseases. When we talk of function, usually, heart is a beating organ. So we need to have images which shows all the phases of cardiac cycle, and this has to be done in various planes that we'll see as we go further. When we talk of tissue characterization, so we have to see two things, whether in the COVID era or otherwise also, especially the myocarditis, we have a clinical presentation just similar to the myocardial infarction. Then lately we have parametric maps that has given definitely an edge over the conventional MR. We will discuss briefly about it. So before we go ahead, we need to find, or we need to see what were the challenges and how this thing has been overcome. And we need to thank the people who were, behind all this, the research and technological environments. So we know that the heart is a beating organ, and we need to physiologically freeze or take all the motions of the heart from systole to diastole. So for that, we need to have cardiac motion compensation, and we do very well with ECG gating. Then beating heart is there in the moving cage. The respiration is another challenge. So we do it with respiratory, motion compensation, and we have a respiratory gating, and there are various techniques for that. As already discussed, plane of the heart doesn't obey the normal anatomical planes, so we have to create various planes which are similar to transthoracic echocardiography. And important is cardiac MR take long acquisition time, so we need to be very, very specific. And for that, we always request our physicians and cardiologists to let us know what information they are looking for. If they just write cardiac MR, we tell them, please avoid all these things and kindly let us know the clinical background and what information is desired, so that we can do the cardiac MR to the best of our ability, in the best of our time, respecting the magnet time, and ensure that patient safety and time is important. So when we talk of cardiac MR, there are three mantras for a meaningful MR. One is appropriateness. What makes us this MR to be acquired in a particular clinical situation. Once then we say it's stick, it's appropriate examination. Then we go for acquisition, and then come interpretation. And this is very important. It's a teamwork. So you need to have good information from our cardiology colleagues. We have to think definitely about the patient, and the radiologist is in between. And the trade-off is between resolution, signal to noise ratio, and the acquisition time. If you want good resolution, definitely acquisition time increases, and so is with SNR. The aim is, what is the aim of cardiac MR then? So we need the scan with the shortest possible time that provides all relevant or desired information, devoid of artifacts, without any patient discomfort. So this is the Guru mantra which we consider the MR. So these are the 5 P's that are typically taught in business schools. I have just modified it. We need to think of 5 P's before we take our patients. Is the prior information, then the preparation of the patients. We'll talk of peripherals, which are very, very important, and then we to ensure all those things which can lead to accidents, and there's spoiler cardiac MR. So we need to all. Then comes the performance in it, and definitely it's a teamwork. And this is one of my favorite slides. And if I have to talk of Pele, who I'm a very big fan of, it was just left us. Success is not by chance. It requires a lot of hard work, and it is the planning which is very important. If you fail to plan, definitely you are planning to fail. And remember, you cannot circumvent any step. Every step counts. And our intent is to make CMR faster and to get away with this notion that MR takes very long time. Yes, it can take long time if you are not well equipped with it. You don't have appropriate knowledge, and there is no appropriateness things that you have considered, and you have to make it cost effective as well. So when we talk of cardiac MR, these are the principles. You need to know how the leads are to be placed. No, every cord has to be straight. This is the this emergency button that you need to give to the patient. So whenever he feels uncomfortable, he can just let us know. And when everything is set right, the patient is cannulated, the cannula vein is patent, electrophysiology or the ECG is coming very nicely. You can, this is a time to start our cardiac MR. The good planning is, it reduces the time and leads to the chances of a successful study. Now we come to the core subject. This was just an introductory one. When we talk of, motion compensation, as I talked, this is one of the slides that I brought from my friend Reda, who works now in Singapore. This is a beating heart, and these are plane of acquisition. And that this heart is lying in a moving cage. And these are the very important statements that you must listen carefully. The acquisition of a single cardiac image usually take around 20 seconds. Newer scanners faster, definitely. And for such long acquisition time, our breathing motions as well as we need ECG signal. Otherwise, we will have non-diagnostic images. So for this, what we need both the motions to be frozen during data acquisition. Let's see how we can do that. For our heart compensation, we need an ECG trace. And usually what we do is when we talk of cardiac MR, we talk of 2 things. We talk of planes and we talk of images. Images can be either a static image or they can be cine image. And it is the cine images that gives our data about the cardiac function, which segments are contracting, which are relaxing, which are akinetic. So this, synchronization is done with ECG, and with ECG synchronization, we do our data acquisition, and that is our system has been, this how the MR equipment works with. And usually we do respiration gating either by, by automated navigation, or we can tell the patient to hold the breath, and typically it is done in end expiration. Got my point? Okay. Now till time we have discussed why there is a need of MR. Number 1. Number 2, we have discussed the basics, how to compensate the cardiac motion and to the respiratory motion. Now, how to do this and how the data is acquired, what are the various sequences, we'll discuss in detail about them. When we talk of pulse sequences, these can be static images and then can be cine images. Okay. Then it can be black blood images, as the name suggests. They will have blood will appear, or the blood pool will appear black. Here you can see the blood pool is appearing bright. These are bright blood sequences. Then the imaging planes. Imaging planes you have to learn like this. When the heart doesn't lie in the body of anatomical planes, so we have to create planes for that. Typically, in a typical late Gallium enhancement protocol, usually the 4-chamber view, or we call it as a horizontal long axis, 2-chamber view as a vertical long axis, and a stack of short axis. Then we can have different views, 3-chamber views, left ventricular outflow tract views, RVOT views, depending on the clinical scenario. So this is our protocol that we follow in PGI. So how we do it, I will repeat it at the last slide. First, we take anatomical images, which can be black blood axial sequences, which are just similar to the CT scan. You can do coronal bright blood sequences if you feel like. Then you have pilot scans. Then based on the pilot scans, we do our cine sequences, typically in 4-chamber, 2-chamber, and short axis. So I give a formula of 4, 2, 3, and short axis. Short axes are always stack of images. Other 3, 4-chamber, 2-chamber, and 3-chamber are usually single slice cine sequences. Remember this thing. If you have to reduce the time, you can bring your short axis stack between when you give the contrast between the early gadolinium and the late gadolinium enhancement sequences. So you can save at least 10 minutes. Okay, so I will go a bit slow from here onwards. Now we will talk of pulse sequences. When we talk of, anatomical images, it is a black blood images. When we talk of body imaging, we talk of spin echo sequences, but in cardiac MR, we do triple inverse recovery sequences or double inverse recovery sequences to get the good anatomical details. The bright blood sequences are now the workhorse. And if you have to remember anything, of this presentation, remember the workhorse of cardiac MR is steady state free precision sequence that give you the axial images or the, the movie-like images or cine sequences. Then if you have to, quantify the flow as we didn't do in Doppler, you can do phase contrast images. Then for tissue characterization, you need to have, edema sequences, which are typically triple inverse recovery scans or stiff sequences that usually we do in musculoskeletal imaging. Okay. Now, additionally, we have parametric maps that we say is T1 maps, T2 maps, and, extracellular volume quantifications. And, you have to customize your scan depending on clinical needs. Now, coming to the dark blood imaging, there are 3 sequences over 3 images at the same plane of the same patient. The first image, which image is better? I think the right lower corner image is better. So this is a typical, spin echo sequence. This is a turbo spin echo sequence, T1 weighted sequence, and this is the inverse recovery sequence. And this inverse recovery sequence, because it gives the good anatomical images, this is the sequence that we apply to get the anatomical images. Okay. So black blood imaging is not T1 imaging, remember, but it's T1 weighted imaging because you get a black blood image. Or anatomical image, which sequence you will use black blood imaging. Okay. Black blood imaging in cardiac MR typically is a double inverse recovery sequence. So what you do is you give a double inverse recovery to make the blood black. Okay. So this is the physics like this. You give 2 inverse recovery pulses before a slice selection is taken off. So with this, the moving blood will not take spins across it into the selected slide. That's how the blood will appear black. I think this is a core physics. So you must understand, or what the thing that needs to be, absorbed from here is, for anatomical images, it is a black blood imaging. Okay. And then comes another sequence, which is again a black blood sequence that characterizes myocardium, is a stir sequence. It's a triple inverse recovery sequence. And we acquire the images at a time when the fluid gives the maximum signal. Okay. Then a small amount of edema, if there is in the myocardium, can be picked up. So this sequence is not a part of routine LG protocol. Remember, this will be a protocol that we need to integrate only when there is a clinical suspicion of myocarditis. Then only we have to use this scan. Otherwise, in a normal LG scan, you need not to have this sequence. Okay. So this is a classically a stir sequence where you see, black is blood and the myocardium, is smooth. And if at all there will be focus of myocarditis or edema, it will appear as a bright signal. Now we come to the bright blood imaging. The bright blood imaging, typically workhorse of cardiac MR is SSFP sequence. Remember, this is a sequence that had revolutionized cardiac MR because previously the sequences used to be gradient echo sequences. The images used to be more greeny, and the blood pool or the signal to noise ratio used to be very low. That used to give very poor quality images. And this is in a modern MR, which give you such an contrast differentiation between the blood and the moving myocardium that now it has become the standard of care or the workhorse of our present cardiac MR. So if somebody asks you what is the sequence for cardiac MR, you should come, with a straight in a single breath hold that it is the SFP sequence or balanced steady state free precision sequence. And this is a sequence that we apply in different planes to get different images. Okay. So when we talk of cine MR, it can be in prospective or retrospective. And cardiac MR, it is a retrospective scanning in which what you do, you scan throughout the cardiac cycle, and then your system will create images. And these images need to have all the images pertinent to the cardiac cycle. Got my point? So when we talk of slice, it should have all the phases from systole to diastole. If your system is very advanced, in a single breath hold, you can have multiple slices in a single breath hold. Okay. So this is how you acquire your data, and you can have all the phases in a single breath hold. So these were the sequences for anatomical images we have discussed. Another we have discussed the cine sequences, which tell about the cardiac function. Now we will talk of tissue characterization. Tissue characterization for edema is a stage sequence for myocarditis. For myocardial scars and fibrosis, is the late gadolinium enhancement. The word late gadolinium enhancement means when we give contrast, it will spread out into the myocardium, and the areas which are scarred, anything which is bright on LG is scarred. Remember, anything that appears bright is a scar tissue in myocardium. Okay, so when we give a contrast, gadolinium, which is typically a T1, it shortens the T1 relaxation times. As we see in this diagram, if it is a normal myocardium and when the acute infarction, there's a death. So please mute yourselves, please. There will be scar, and this gadolinium will get trapped within this scar, and you will find on the late gadolinium enhancement as these images. Okay, you will see the bright, the structures, bright myocardium, which is a dead myocardium or a scarred myocardium. Here, what Dr. Vanita Arora was asking, that these patients can be, liable for arrhythmias, and these is the region, that will tell, say, it is the anterolateral wall in the mid cavity area falling into this AHA, this segment, where she can place the lead very well, which she will agree with me. Before the advent of cardiac MR, this information could only be indirectly be, derived from electrophysiology. But now how you can see that which area is abnormal on cardiac MR. Now there's a line, this is also very important. We'll talk about this, the contrast kinetics as well. When we give contrast, this is how the contrast goes about it. And when there's a contrast difference is maximum between the scarred myocardium and the normal myocardium, here is the time which we call as T1 time to get our images. What is our intent? The intent is to make the myocardium black so that any small amount of scar, in fact, the today's present MR, even 1 gram of scarred myocardium can be picked up. So how we do it with, we give a 180-degree inversion pulse, something like this. Okay, and as it longitudinally recovers, and the difference between the scarred and the healthy myocardium is maximum, and this is the time when we take our images, so that any small amount of scarring or fibrosis is picked up. And based upon the characterization of enhancement, we can tell it is ischemic, it is of different nature, it is of myocarditis nature, it is of there is a lot of pathologies depending on the type of enhancement that we can reach to a diagnosis. And the primary of them, which has evolutionized probably, is this amyloid, sarcoid, tubercular involvement, then other granulomatous diseases, scar quantification in hypertrophic cardiomyopathy, endomyocardial fibrosis, amyloidosis, Addison Fabry's disease, which otherwise diagnosis had been very difficult. Now we talk of here till the time we have talk of principles, and we have talked about the various pulse sequences, their physics, their principles, and their applications. Now we talk of protocol. Okay. In protocol, as discussed previously, I am repeating again in much details now. As when the patient is on table, you take scouts. You scout automatically, it gives you the images in 3 planes, that is axial, coronal, and sagittal. These are they are low resolution static stack images. From there, you find where is the position of our heart, and based on that, you take a stack of axial images starting from the thoracic inlet to the dome of diaphragms. Okay, so this gives you the anatomical images. Based on that anatomical images, you draw pilot sequences typically in 2 planes. One is vertical long axis or 2-chamber view, and we take 3 slices of short axis. Based on those images, we start our cine sequences, which will be the main cardiac MR in which we drive our volumetry and analyze about the motion abnormalities. Then based on your late Gallium enhancement, we characterize the myocardium. And if you have a facility of parametric maps, you can integrate those in a particular clinical situation. Okay, this what we do is something like this. The body planes are, this is the stack that you get, once the patient is in the gantry as axial planes, coronal planes, and sagittal planes. Okay, got my point? And these are the various planes of the heart as short axis, horizontal long axis, or the 4-chamber view. 4-chamber view because you get the images of the 4 chambers of the heart as LV, LA, RV, and RA. This is a 2-chamber view in which you get LV, and LV means left ventricle and the left atrium. How we do that? So these are the images that you got. Then you take an axial slices something that you do with CT scan, and this is on the center of heart. You put a shim box so that you get a uniform signal. Once you do that, this is what you get. So you will get videos are not playing, I suppose. Okay, no matter. So you will get a stack of slices from the thoracic inlet to the domes of diaphragm. So what you do this, after getting that, what you do is you place one of the slice where axial slice where you get 4 chambers. So this is RA, right atrium, right ventricle, left atrium, left ventricle. Okay. And you draw a line that transects the LV apex and the mitral wall in the axial slice. And with this, you get the vertical long axis pilot scan. Remember pilot scan. Okay. Once you get this VLA pilot scan, you put it over here, and this is your the axial slice covering the 4 chambers. You draw 3 lines, which is 8 mm slice covering the base, mid body, or the mid cavity and apex. And these are the 3 cine slices that you'll get at the apex, at the base, mid cavity, and apex. Got my point? Once you get that, you get a VLA view, short axis view. You draw a line again which transects the LV apex, mitral wall, and on short axis views goes through the mid LV and crosses the RV apex. And with this, you get, this video is not playing. You get a cine 4-chamber view. Okay, I think there is some problem. This video is not playing. Once you get that, you get a 4-chamber view. Again, you take a short axis slices and put a line plane which is parallel to the interventricular septum. And with this, you get a 2-chamber cine sequence. Why we not playing? Okay, so if you have to take a 3-chamber view, that I'm not going to discuss because it is going to confuse more. And I always told, whenever we talk of short axis, it is always a stack of images. And this is the set of images that is vital for any cardiologist to see, or for that matter, any radiologist, cardiac radiologist, to interpret images and to get the volumes. So what you do, you cover whole of the LV cavity starting from the base to apex. Usually it is covered within 10 to 12 slices. And the usually slice thickness is, what we do is I give a mantra of 10. Either should be an 8 mm slice with 2 mm thickness, or 6 mm slice with 4 mm thickness. And the temporal resolution between the phases should be less than 45 milliseconds. Once you do that, this is a stack of images that you get videos are not moving. I don't know what. You will see the contracting images. You will see the short vexes. The heart contracting like this. All the walls will contract and will thicken. So once we do that, you give the contrast. Here you give the contrast and you see the first pass perfusion, and immediately you do an late gadolinium enhancement images. And if there is a thrombus, you can see very well on the early gadolinium enhancement images. Then you have to wait for 5 to 7 minutes to take the images in late gadolinium enhancement sequences. And there also you take a single slice of vertical long axis, single slice of horizontal long axis, and 3 slices of short axis from base, mid cavity, and apex. Okay, let's see how it is done. Another thing, if you want to have phase flow quantification, then you have to do these sequences, and we usually reserve for specific conditions, especially in congenital heart diseases on operation of aorta. So I think I should skip this as well. The late gallium enhancement, depending on the type of enhancement and the location of enhancement, we can say whether it is ischemic in nature, not ischemic in nature, and so and so forth. And these are the specialized views. Here video is moving, I suppose. Can you see this video moving? So this is a left ventricular outflow tract view. This is the right ventricular outflow tract view. And this is one of the views to show the LVOT. So these are very important ones. Once we know the clinical scenario, we routinely do not do these planes and these sequences in a routine cardiac MR. This we must know. That is why clinical scenario and the information so desired after a given examination is very vital. This again one of the aortic arch view that is sometimes required. These are the short tau inverse recovery scans to see the myocardial edema. If there is an edema, you will see such type of bright signal. And you have to take in 3 views. This is a 2-chamber view, 4-chamber view, and you have to take 3 slices transecting the LV. This is from the base, mid cavity, and apex. Okay. At the same time, when you give contrast, if you want to have information of the pulmonary arteries or aorta, you can definitely do an MR with the as well. So this was a typical cardiac MR that you do, and now we have the other tools to characterize the myocardium, and that we can do without giving even the contrast, that we typically called as parametric maps. And the nomenclature you should know, it's T1 map, T2 maps. And once you give contrast, you can quantify the extracellular volume quantification also. The new things that are coming up are 3D and 4D flows, which are very important for aortic valve diseases and effect on myocardium. Then flows around the dissection flaps and imaging with devices. Now we have MR spectroscopy is coming in a very big way. Black blood LGs, just listen to these terms. It may be, it may be difficult for you to grasp, but I thought I will put one slide only. Then we have real-time cine imaging, motion-corrected LGs, so and so forth. And how we need to customize our MR scan depends on the clinical need. Say if there's a clinical need that somebody wants to know whether this patient is having arrhythmogenic right ventricular cardiomyopathy, then you have to include your cine axial scans as well. If it's a myocarditis, you have to add stir sequences and mapping if there is possible. For tumors, you need to have TSC sequences or turbospinico sequences, pre and post contrast. There is a pericardial disease, you want to see the constriction, you want to have real-time cine sequences. And for pericardium, you need to have T1 axial, TSC, pre and post contrast sequences. So you have to, what I mean to say is, first you need to know what is the basic cardiac MR protocol, what are the various planes, what are the various sequences. You must know that there are, when we talk of images, they are static images, they are cine images. And based on the clinical picture, you have to customize your MR scan. This is one of my, last slides, which is very philosophical. I have tried to make things simple, but they are not that simple. And it is the hard work and your passion, that makes the, things which are either harder or complex simple. And there is no shortcuts to it. And success, I tell you, whether it's home or personal problems or where we practice, success, it's not just an accident. It is a product of your hard work, perseverance, learning, and sacrifice, and more importantly, what you love. If you love, you can make mountains move. Otherwise, you will find this talk also very difficult. But I tell you, this is not very difficult. It is very exciting. It is very innovating. And I tell you, if you have to talk of the world leaders, the way forward in cardiology is the integration of this neurotechnology into the cardiac practice. So take home points. When we talk of pulse sequences, the black blood is for anatomy. Remember this thing. When we talk of function, we talk of steady state free precision, and it is a workhorse of cardiac MR. We must know that this heart doesn't lie in the plane of the body, so we need to create planes, and knowledge and about the various planes is very important. If you want to have a flow quantification, you need to have phase contrast imaging. For myocardial tissue characterization, the delayed gadolinium enhancement. And definitely, I've said this terms n number of times. Always talk to your cardiologist or referring clinicians or referring physician and surgeons. What is their clinical need, and we have to customize the scan accordingly. With this, I thank you, everyone for having this opportunity, especially GAPIO and GARTIO, to present, this very valid topic on this platform. If there are any questions, I would like to, answer them or at the end of the session. And with this, I come to the end of at least my talk. And thank you each and everyone.
Thank you, Professor Singhal. It was an excellent presentation, and the love and passion you have for cardiac MRI was seen in your presentation. I would request you to please stay online with us. We will take the questions at the end of the session. And I request everybody, whoever has the question, kindly put it on the chat box so that we can take those questions at the end of the session. Now, moving on to the next speaker, I have the proud privilege of introducing Ms. Anzar. Hello.
Hello.
Yeah, I'm audible, no? Right? Okay. Yeah. So Ms. Anzar is currently working as senior MRI technician, technologist at Elstar MIMS Hospital, Calicut, Kerala, and she has experience in cardiac imaging, body imaging, vascular imaging, and neuroimaging. She's been involved in a lot of research projects like artificial intelligence-based system for cerebral arterial stroke imaging and prognostication, and stroke classification from CT scans using 3D convolutional neural network, which has been even accepted in the publication in biomedical signal processing and control as a research paper. That's awesome. And Ms. Anzar has contributed as a co-author in publication of a book titled Semi-Automated Mapping of Occluded Arterial Segments in Acute Large Vessel Stroke in the Journal of Stroke and Cerebral Diseases. Today, she's going to talk to us on challenges and solutions in cardiac imaging. Over to you, Ms. Anzar.
Thank you so much, ma'am, for such a kind, nice introduction to me. Respected faculties and dear delegates, very good evening to all of you. Myself, Ajmi Mall, working as a senior MRI technologist in MIMS Calicut, Kerala, India. Today, I'm going to discuss a topic about the challenges and solutions when we are doing a cardiac imaging. As all we know, there is also a challenge for the MRI technologists also to appropriate images, and it is very crucial for the patient diagnosis and further treatment. Cardiovascular MR, which is a set of MR techniques designed to assess the morphology, cardiac morphology, ventricular function, myocardial perfusion, tissue characterization, and flow quantification, all. Moving on to the since MRI is a non-invasive tool and free of radiation, so it is suitable for monitoring and treatment and follow-up. So it is very challenging for acquiring the images of the heart, because as all we know, it is continuously moving. It's not the imaging of the cardiac MR is not that much easy as that of the stationary organs. So the main challenges that we are facing when a cardiac MR is dealing with poor breath holds. If the patient is not holding the breath properly, it will be the gating will not occur proper. Then the images caused by artifacts and other challenges when the patient with arrhythmia, irregular heartbeats, and other challenges in cardiac MR includes the different artifacts, including metal artifacts, and patients with, suppose a patient with pacemaker, it is a challenging part for the technologists. And sometimes when we, for getting the proper analysis, we will not get proper flow analysis due to proper wing values. And after the contrast medium also, sometimes in the delayed contrast images, the myocardial suppression will not occur proper. So these are the challenging things occurs when wearing a cardiac MR images. The major thing is the motion compensation. In order to compensate the motion artifact, we can cardiac synchronization method or a respiratory gating method. Cardiac synchronization with ECG, it's a way to achieve this goal. There are two ECG synchronization methods are there. One is called the prospective gating method. This method uses the preceding ECG R wave as a trigger to acquire a segment of in the case space. And other one is the retrospective gating. In case of gating, we are continuously acquiring the images. And other technique in order to synchronize cardiac synchronization is the single shot acquisition. This technique allows for the acquisition of the data of the entire LV, suppose it 9 or 10 slices in a single breath hold. And we can compensate the motion effects either by doing the respiratory gating also. Respiratory gating we can perform either by breath hold imaging or the navigator techniques. So as I told, cardiac synchronization with ECG is a way to achieve the goal. And here we are connecting the ECG electrode and the system has the R software. From the R wave will detect the the software will detect the R wave, and there is a synchronization pulse in between the pulse sequence controller. Thereby the gating will occur and we will get the images. So the placement of the ECG electrode will be very crucial for getting the proper gating. So in order to get a proper ECG, we should shave the patient is advised to do shave chest hair in order to make a close contact between the skin and the electrode, and should use the low resistance or MR compatible electrodes, or we can wipe the wet or sweaty skin with pad and try to position the electrodes in the correct placement itself, because the reposition of the electrodes will not hit properly. And make sure the patient inside the bore should remain cool so that sweat build up. And always maintain a good distance between the electrodes, because it will cause the magnetohydrodynamic effect. It will affect the image quality too. So the small distance reduce the noise, but decrease the amplitude connect leads and in a paired order orthogonally. This is the image or the diagram demonstrating the placement of electrodes in a proper way. And on most systems, this is the VCG, vector cardiogram images. On most systems, the detection of the R wave as a trigger has been replaced by vector cardiogram. The information from the two leads are simultaneously used to get the magnetic action of the electric dipole. And can check the accuracy of the placement of the electrode by checking the VCG amplitude value. The recommended amplitude of VCG is 1 millivolt, minimum of 1 millivolt, and a satisfactory trace will display as a green waveform. If the amplitude will be less than 0.8 millivolt, it will appear as the yellow one, and if 0.4 millivolt, it will appear as the red. So by checking this ECG waves and the amplitude value, we can reposition the electrodes in order to get the proper gating. Next challenge is when doing a cardiac MRI with arrhythmias. Arrhythmia, it simply refers to proper beating of the heart, whether it's irregular, sometimes too slow. So in arrhythmia patients, how we can resolve it by using a heart rate or rhythm control before, by giving a blocker or anti-arrhythmic medication before starting. And we can use the arrhythmia rejection. But when we are using the arrhythmia rejection technique, the breath hold scanning at time increasing. And we can go for a prospective triggering. When we are prospective triggering, the signal to noise ratio or SNR will be reducing. And we can use a real-time imaging. When we are using the real-time imaging, the temporal resolution and spatial resolution will compromise, but we will get better images. And sometimes the patient is unable to hold the breath properly. So we can resolve this problem by reduce the number of slices of breath hold, but it will simply increasing the scanning time. And we can reduce the number of phase encoding steps. The reduction in the number of phase encoding steps also reduce to noise ratio. And we can go for the scan with increasing voxel size. This increasing voxel there goes decrease in spatial resolution. And for the parallel imaging techniques, when using a parallel imaging technique, the SNR will drop, which sometimes cause artifacts. And we can use the respiratory navigator technique, and we can acquire the images with inspiration. And if the patient is not cooperating at all, and the study was necessity, then we can postpone the study under GA. This is a visual example of images acquired from the same volunteer performing 4 different breath hold behavior during acquisition. These are the images showing end diastole, and these are the end systole images. From these images, you can clearly understand the importance of proper breath hold when acquiring the CMR images. Other one challenge that we are facing when doing a cardiac MRI is the artifact. One which is usually occurs that the wrapping artifact or foldover artifact, which is usually the reduction in the FOV. We can resolve this wrapping artifact by increasing the FOV, or we can use a selective tissue saturation bands, and we can add the phase oversampling. Sometimes the phase oversampling will enable the scanning time will be more, but the image quality will improve. And we can use a surface coil. We can select only relevant coiled elements, and other one is we can swap the phase and frequency direction. And other artifact which is occurred during the acquisition is the ghosting artifact, which is due to the respiratory motion. We can avoid this ghosting artifact by a strict breath holding plus acceleration technique. So in combination with the breath holding techniques, we can do the acceleration technique. So the breath hold time will be reduced. Thereby the ghosting artifact will reduce. And we can swap the phase and frequency direction. And we can use the selective tissue saturation bands to suppress the signal from the anterior abdominal wall. And we can go for the navigator techniques or the gating techniques. The navigator techniques will increase the scanning time, but quality will improve. And another ghosting artifact is due to the motion or pulsatile that we can resolve by using the ECG triggering or gate. We can go for a flow compensation technique. We can use a selective tissue saturation bands to suppress the blood signal, and also we can swap the phase and frequency direction. Other artifact occurs during the cardiac MR acquisition is the flow-related signal loss and flow jets. Here we can reduce this signal loss by reducing the echo time. We can use the compensation technique. And other artifact is the dark rim artifact. In dark rim artifact, which simply refers to a band of the transient low signal in the endocardium during the early phases of the myocardial perfusion. And we can reduce the dark rim artifact by reducing the contrast dose or the infusion speed or the flow rate. And is the in-plane spatial resolution, thereby we can reduce the dark rim artifact. Other artifact which is causing is the radio frequency interference. This we can avoid by checking the source of interference. Suppose the door will be open, the RF interference will cause. So we can make sure that the door will close or there is not a chance for the RF interference, and we can repeat the scan. And another one is slow flow artifact. Slow flow artifact will up the hyperintense vessel sign. This slow flow artifact usually occurs in the T2 weighted images. We can reduce the slow flow artifact by increase pre-pulse slice thickness. And other common occurring in all MR acquisition is artifact. So the metal artifact reduction, the metal artifact is more prominent in the gradient echo images, and it is less prominent on the spin echo images. So when doing a cardiac MR, we can avoid the balanced SSFT imaging, and we can acquire the more sequences with spin echo pulse sequences. And if the patient is with a pacemaker, we can change the mode, and we can perform the under limit under particular condition. And in order to reduce the artifact, we can go for the wider bandwidth techniques. Next is the next challenge is the phase velocity encoded flow. Sometimes we won't get the proper flow analysis due to proper selection of the velocity encoding or Wenck value. So choose the appropriate imaging plane which is perpendicular to the direction of flow in order to get the proper flow. And can choose the adequate resolution in order to get a proper flow. The spatial resolution is minimum of 4 to 6 pixels vessel. And choose appropriate Wenck also. For a normal aortic flow, it's 150. For a pulmonary, 100. And if any pathological situation is there, the Wenck accordingly. If Wenck will be more, the aliasing artifacts, and when will be high, it will underestimate velocity. So ensure the proper Wenck before the flow analysis. And the other challenges when I'm usually occur the poor myocardial suppression or the nulling of the myocardium in and late gadolinium enhancement. And we can resolve by setting the TI or inversion time in order to null the normal myocardium, and scan mid or late diastole to minimize the motion artifact. Can use the saturation bands across the spinal column and the anterior to reduce the ghosting artifact. Better we have to go for a TI scout images and select the TI value from the scout images, apply it on the PSIR sequences, then we get the proper enhancement if the enhancement is present. Here, the TI scout images is 12 images acquired as part of an inversion time mapping sequence with the TI value ranging incrementally from about 200 to 300 milliseconds. Here we can see that the best suppression of normal myocardium corresponding to a TI of 260 milliseconds. So we can repeat the scan with the TI of 260 or the value that we get from the scout images, and we can repeat the scan. Thereby we can myocardial signal. So these are the main challenges and the resolutions that occurring when doing a MR. Thank you.
Thank you. Hello. Yeah. Thank you, Ms. Ajmimol. It was an excellent presentation. I think in the paucity of time, let's move on to the next speaker so that we are able to conclude the seminar in time. So it's my proud privilege now to invite a friend and colleague, Dr. Nidhi Goyal, who's a senior consultant in radiology at Indraprastha Apollo Hospital, New Delhi. She's also a thesis guide and an assessor of National Board of Examination. She's an editor of the Journal of Orthopedics and reviewer for Journal of Radiology, and has her expertise in cardiovascular imaging with special interest in cardiac MRI, MSK radiology, and neuroradiology. She has more than 10 papers in various books, 10 chapters in various books, and more than 20 publications in various national and international journals. She's made worldwide presentations, and she's also been awarded the IRIA President Appreciation Award. So Nidhi is a great help in my day-to-day practice. So welcome, Nidhi, and over to you.
Good evening, ma'am. Thank you so much for such a fancy introduction. Good evening, Dr. Sibal, and congratulations, Dr. Vinita and Dr. Sibal, for this lecture series that we have started. I will straightforward go to the lecture because we are running short of the time. I will just share my screen. Just a minute. Dr. Vinita, is it visible? Well and good?
Yes, of course. Yeah.
Okay, thank you. So after an extensive discussion on how we are acquiring the images, I'm sorry, I'm not able to, yes. After an extensive discussion on how we have acquired the images and how the technical things can be taken care of, beautiful lectures with Dr. Singhal and Ms. Atmi, I will not go into the details of the technicalities. Now we will only talk about the interpretation of the images and what are exactly the indications and where cardiac MRI can help us in understanding these images and solving the clinical questions. I absolutely agree. There is a quantum leap in the technological advancements that have happened. I'm sorry, I'm just switching over. Okay. So there is a quantum leap in the technological advancements, and this is how the images now look like. The cardiac MRI being a multifunctionality imaging modality, it means it's a non-invasive investigation. The most important thing, it's a non-invasive, non-ionizing radiation. We don't use any radiation in the cardiac MRI. That is the biggest benefit of cardiac MRI. It has unparalleled image quality with highly accurate results. And when we acquire the cardiac images, this is how the images look like in various planes as has been described by Dr. Singhal. Coming to this, I will just show this small video to show you how we acquire the images in three-dimensional planes, plus how the volumetric data is acquired. And when we acquire the volumetric data and these kind of cine images, it's not only the morphology that we assess from the cardiac MRI, it's the functionality, which makes the cardiac MRI an edge over other modalities in terms of telling about the morphology, the functionality, and especially the quantification of the blood flowing through the different chambers and different vessels of the body. So if we talk about the indications, if we talk about the indications, the primary indication of the cardiac MRI, if we gather all these indications, the most important indication always remains the evaluation of ischemia and the inducible ischemia. The second important question that we answer through cardiac MRI are the cardiomyopathies. It can be ischemic, it can be non-ischemic cardiomyopathies, and the non-ischemic cardiomyopathies usually have a categorization of dilated, hypertrophic, infiltrative cardiomyopathies. The other things that are being asked and being answered by cardiac MRI, CMRI, are the various types of cardiac masses and differentiation it from the thrombi or pseudomasses. Pericardium is another structure which is a very thin layer of structure outlining the cardiac, and the pericardial abnormalities are beautifully seen on CMRI, even it being a very thin structure and not appreciated well on other modalities, especially the CT scans. Arrhythmia evaluations, which we're doing a lot for Dr. Vanita, and congenital heart diseases, pre-op and post-op follow-up conditions, then mediastinal vascular diseases and valvular assessments. So these are the various categories where cardiac MRIs make, CMRI make an edge over other modalities in answering not only the functional, but not only the morphological assessment, but also the functional assessment. So how and where the cardiac MRI stands right now. So if we talk about cardiac MRI, sorry, it's just skipping. The most established technique right now is the PET. Cardiac MRI in terms of sensitivity and specificity is very close to PET scan if we talk about the functionality and the assessment of the myocardium is concerned. However, it has an edge over echo and SPECT in two terms. One, we don't have a limitation of window because assessing the apex and the anterior medial wall of the myocardium is usually tough because of a low windowing through these structures. In cardiac MRI, since we are evaluating the entire heart in multiple planes, we don't have any limitations. Even in the fatty patients, even the patients who have a lot of fat, a little heavier on the heavier side of the weight, these limitations are not the limitations for cardiac MRI. The third thing, of course, which we have already discussed, lack of radiation in the cardiac MRI makes it a little much better than echo and SPECT imaging, and very close to the PET imaging in sensitivity and specificity. So the first and the most important thing is ischemic heart disease. In ischemic heart disease, what cardiac MRI can help us? Cardiac MRI not only tells us whether the myocardium is viable, it helps us to tell us how much part of the myocardium is viable. Whether that myocardium, which is viable, has inducible ischemia, means if we put that particular myocardium under stress, there will be an ischemia in that particular part of the viable myocardium, and how much is the infarcted tissue, means we can quantify the scar. Quantification of the scar is something in which cardiac MRI is actually a gold standard investigation. Remember that. We can also, if it can tell all this, we can also give a roadmap for the vascular and the non-vascular interventions to the cardiologist. Along with telling the morphology, viability, and the inducible ischemia, the evaluation of the ventricular function by telling the ejection fraction and diastolic volumes and systolic volumes of the right and the left ventricle, we can tell us the total functionality of the residual functionality of the diseased heart in a particular patient. After telling these acute conditions, in the same sitting, we can also tell about the complications of myocardial ischemia, which can be aneurysms, which can be thrombus, and which can be valvular regurgitation. We will see all this in these images. Comprehensive evaluation, how we do this, how we say that there's a viable myocardium, how we say that it's a non-viable myocardium. Comprehensive analysis of the images, as we have already seen how we are acquiring these images in Dr. Singh's lecture. The comprehensive evaluation of the cine images means when the heart is moving and we can see the heart contracting like this. So it will tell us about the motion, means which part of the heart is moving and which part of the heart is moving less than the rest of the normal myocardium, and which part is not moving at all. So evaluation of the cine imaging, perfusion means early gadolinium enhancement imaging, late gadolinium enhancement imaging, in short axis view and in 4-chamber view. Evaluation of all this together will give us the accurate results of which part of the myocardium is actually scarred, is infarcted, and which part of the myocardium is under viable but is under a inducible ischemia. For example, just to exemplify and just to give you a simplified version of this, it's an oversimplification, but we have to understand cardiac MRI by simplifying it further and then going into the details. For example, if this is the normal thickness of the myocardium, this is not the normal thickness of the myocardium. This is a thinned out myocardium. And the same area, if you can appreciate, is showing the enhancement. Enhancement is seen as a white line. Can you see that this is a white, this is black. So the myocardium will not take up the contrast. It is only the scar tissue which will take up the contrast, as already been explained to you. So correlating these cine images and the abnormality with this late gadolinium enhancement and seeing it in the short axis as well as the 4-chamber view will exact disease myocardium, and you can quantify and tell that this much part of the myocardium is diseased, and this is where we can tell the scar quantification, and along with it, scar quantification, if you also are giving a perfusion imaging, means early gadolinium enhancement. This kind of enhancement will tell you inducible ischemia in the myocardium. So these are the two things that we tell in the morphology part. So, but when we are assessing these conditions, as I have already told you, look for the late scarring. Means already the patient had some kind of myocardial ischemia. The heart may have some residual complication. For example, can you see this thinning of the myocardium and bulging of the myocardium? Means focal aneurysmal formation at the site of scarring, along with it, thrombus formation within the dilated myocardium. These are the things, all these things we can tell, in the thrombus formation within the dilated ventricle. So all these things we can tell in a single study, means viability, scar tissue, and the complications of the MRI. All these things can be investigated, can be told within a single study of cardiac MRI. So if we see the wall motion abnormality, gadolinium enhancement, this all tells us about the viability assessment. If you will be able to tell the viability assessment, you will be able to characterize the total amount of myocardium which is not working, which we say is a scar quantification. Along with it, you will be able to do the functional imaging. As I've already told you, morphology and the functional imaging. You can tell about the right ventricular ejection fraction, you can tell about the left ventricular ejection fraction, and diastolic volumes and systolic volumes, and additional finding in the mediastinum. For example, you can look at the pleural effusions, you can look at the pericardial effusions. So these are all questions that you should be answering if you're reporting a cardiac MRI of a ischemic heart disease. So just to give you a brief, the kind of enhancement that we see, supposedly a patient comes to you, you are not very sure, the physician is not very sure, we are not very sure that kind of a chest pain is actually because of some kind of an ischemic heart disease, if the coronaries are normal, or some kind of a non-ischemic cardiomyopathy. So when we see an enhancement in the myocardium, the localization of that enhancement in the part of the myocardium will help us to tell the pathophysiology. This has already been covered in the previous lecture, but I will just go briefly through it. For example, if there is a mid-myocardial enhancement, as we can see in the second image like this, patchy mid-myocardial enhancement or this kind of a linear mid-myocardial enhancement, it is usually a non-ischemic cardiomyopathy. It is never a ischemic cardiomyopathy, always remember that. And if there is a sparing of the subendocardial myocardium like this, and if there is a homogeneous entire, means circumferential involvement of the myocardium, these usually are the infiltrative disease like amyloidosis or fibrosis. However, if the enhancement is transmural with thinning or subendocardial, it is usually an ischemic cardiomyopathy. So after coming from the ischemic cardiomyopathy, the next question that we need to answer is the non-ischemic cardiomyopathies. What are the various things that comes under non-ischemic cardiomyopathy? Hypertrophic cardiomyopathy, dilated cardiomyopathy, if they present as if it is a first presentation. Okay, then is the infiltrative or inflammatory cardiomyopathies, which include the granulomatous like TB cardiomyopathies or sarcoidosis kind of cardiomyopathies. Then myocarditis. Myocarditis has become very important, especially after the COVID era. Then right ventricular cardiomyopathy or dysplasias, as we say. And iron overload, I will tell a few things about iron overload after discussing about the cardiomyopathies. So hypertrophic cardiomyopathy is something which is not a diagnosis that we do from cardiac MRI. It is definitely done by echo imaging. But what is the role of, what exactly is the role of cardiac, what is exactly is the role of CMRI? CMRI tells us about the involvement of the extent of myocardium, means saying that whether it is symmetrical myocardiopathy, whether it is asymmetrical cardiomyopathy, or whether it is a focal hypertrophic cardiomyopathy. And if it is a symmetrical hypertrophic cardiomyopathy that you can see, the other things that you have to tell are the complications. What are the other complications that you need to tell? One, involvement of the interventricular septum. Second, obliteration of the mid cavity of the ventricle. And dilatation of the apex. These are the associated complications which are beautifully seen in CMR. What is one more thing which is to be told if you're reporting a CMR in a patient of hypertrophic cardiomyopathy. I will just go to the next thing and we'll run this video. It's a SAM, systolic anterior motion of the mitral leaflet. So these are the various things which, along with the static images that we acquire and the cine images that we are acquiring, we can answer. So hypertrophic cardiomyopathy, complication of hypertrophic cardiomyopathy, of how much is the involvement of the myocardium, how much is the obliteration of the cavity, and whether it is associated with SAM or not, and whether there is an apical obliteration of the cavity, are being very well answered by CMR. Dilated cardiomyopathy, important questions, important answers that we have to answer. How much is the myocardium involved? Whether it's a single ventricle which is involved, whether it's two ventricles or multi-ventricle, two ventricles, or even there is an atria which are involved. Whether there is a myocardium normal, it is just a dilated cardiomyopathy, or whether it is a myocarditis which is leading to dilated cardiomyopathy. So these are the various things that we are going to assess with the CMR. I have already discussed this. I will not go into details. This is another example how we can tell from CMR what kind of pathophysiology we are dealing with. As you can see, these are black blood images. These are axial black blood images in which we can see multiple enhancing, homogeneously enhancing lymph nodes in the mediastinum, in the paratracheal region, which are kind of specific for sarcoidosis. And when we see the late gadolinium enhancement images, axial section, short axis sequences of through myocardium, we can see that there is a white line. White line depicts the late gadolinium enhancement within the myocardium. One. Second, the distribution of this enhancement. There is a classical sparing of subendocardial tissue. This is a mid-myocardial enhancement representing the inflammatory cardiomyopathy secondary to sarcoidosis in this biopsy-proven case of lymph nodal sarcoidosis and involvement of the myocardium. So after discussing about ischemic heart disease, cardiomyopathies, the next thing that we are going to answer specifically are the arrhythmogenic focus. So in the arrhythmia evaluation, what we need to answer, what we need to tell. CMR is a comprehensive one-stop imaging technique for evaluation of arrhythmia. What causes arrhythmia? Arrhythmias are usually caused by myocardial scarring. Even the smallest possible scar now can be easily and very well evaluated by the present day cardiac MRI sequences that we evolved. So not only about the myocardial scarring, the CMRI tells us about the anatomical abnormalities and variations which may be the reasons for arrhythmia, and good functional assessment of both the right and the left ventricle, making CMR as an ideal investigation for arrhythmogenic focus identification. And this functional abnormality, what kind of function the right and left ventricle have, will help us to guide the specific treatment to the concerned physician, to the cardiologists, because if we are able to tell them this is the functionality before giving the treatment, they will be able to decide on the treatment very well according to the initial functionality even before. So I will again give you an example through this image. Can you see this enhancement? This is a scar tissue. The scar tissue will always enhance. We know that why. It has already been explained. So in this substrate fibrosis, identification of this fibrosis through enhancement in the anterior medial wall and the inferior lateral wall of the myocardium, you can see that we can quantify the total scarring. We can quantify and tell this is the scar tissue and how much myocardium is involved. So preoperative procedures like CRT placements, if we are able to exactly quantify the scars, the CRT replacements become easier if we add on the functionality. If the left and the right ventricle function is poor to start with, we know even after the placement of CRT, the prognosis will not be very good. So the poor function procedure will help us about the prognostication of the treatment that we are doing in these patients. Okay. So I will just skip this video and we will directly go to the cardiac masses. How CMRI helps in telling the cardiac masses and how it helps us in differentiating it from the thrombus. Cardiac masses and thrombi, again, are diagnose on echo images, but how CMR helps. First, it helps us to differentiate the tumor from the thrombus and from the pseudotumor. Once you are sure whether you're dealing with the tumor or the thrombus, it will tell us about the location and the anatomy, tells us whether that tumor is benign or malignant, or whether it is actually a primary disease of the cardiac or it is a secondary metastasis to the cardiac. For example, in this enhancement image, you can see that there is a filling defect kind of a thing, which is iso-intense to the muscle within the ventricular cavity, and this is a thrombus. And the early gadolinium enhancement and the late gadolinium enhancement will help us to differentiate a thrombus from the tumor. Plus, normal, what I will say, normal structure means focal hypertrophy of the myocardium or a hypertrophy of the papillary muscle will be differentiated very well from a tumor or a thrombus if we will be able to assess the early gadolinium enhancement scans and see the enhancement of that particular structure along with the normal myocardium from a tumor or a thrombus. So remember that. So early gadolinium enhancement, late gadolinium enhancement will help us to differentiate thrombus from the tumor and from a normal tumor-like structures like a hypertrophic cardiomyopathy or a hypertrophic papillary muscles from any of these diseases. And this is how the actual lesions or the tumor looks like. You can see this is a well-defined mass lesion, atrium, which is attached to the intra-arterial septum. The mobility of this mass, the location of this mass, and enhancement of this particular mass will help us to differentiate that this is a classical case of mixing. To exemplify this same thing, this is a patient with a primary non-malignancy. You can see there is a mass lesion involving the myocardium as well as the pericardium. And this particular lesion has the same characterization and enhancement pattern as a lesion seen on the surface of the liver. So this patient can be saved from a biopsy, unnecessary biopsy from a myocardium, if we are able to tell the characterization that these two are actually metastasis. One is a myocardial and a pericardial metastasis, and the other one is a hepatic metastasis from a known primary. So after ischemic heart diseases, then coming to the cardiomyopathies, and then differentiating the cardiac masses and the tumor thrombosis, we will come to the pericardial pathologies. What are the various pericardial pathologies that we need to see when we are looking at the cardiac MRI? One is the pericardial thickening, which can be seen on the CT images and as well as echo. The other one is a differentiation of the constructive from the restrictive pericarditis. Third is the pericardial effusion. Fourth is the pericardial lesions and congenital and post-operative pericardial defects. Pericardium is actually a very thin layer. If there is no significant thickening, it's only the enhancement of the pericardium, it is very tough to appreciate this on echo and even on CT scan. So post-gadolinium scans will show enhancement of the pericardium like this. Can you see these thin structures surrounding the myocardium? Okay, so this kind of enhancement will tell us that we are dealing with some kind of a pericarditis. CMRI beautifully shows the pericardium, its enhancement, its thickening, and if there is a mass or there is an effusion associated with pericardium. This can be because of the characterization of MRI to differentiate clearly between the fat, fluid, and the soft tissue. Able to see the fluid separate from the pericardial thickening and the fat separately from the pericardial thickening. So you will be able to appreciate whether this is a pericardial thickening, we have an effusion, or we have a mass lesion. For example, this is a case, this was actually a case of, I have borrowed this case from Dr. Vimal Raj, and this is a case in which there is a pericardial lesion, and this is a proven case of pericardial lipomatosis. In cardiac MRI, we are clearly able to see that there is a lipid component to the pericardium, plus there is a pericardial thickening, and plus there is a small component of pericardial effect. So this was actually a case of pericardial lipomatosis. Similarly, in the cases, in which we have hemorrhagic pericardial effusion, take the use of T1 weighted images. T1 weighted images and T2 weighted images will beautifully show you the content of the pericardial effusion, whether it's hemorrhagic or non-hemorrhagic. And in the cases of hemorrhagic pericardial effusion, we really need to worry about the tamponade and the cause for that pericardial effusion. So after discussing all this, comes the valvular assessment. Always remember, in the combination, as we have seen how we acquire the images, when we acquire the cine images, means when the heart is moving, plus we are acquiring the volumetric images, means heart is moving, plus we are able to see how much blood is moving through that heart, and quantification of that blood, which is moving through the moving heart, will help us to give the flow quantification through the walls and through the vessels, means aorta, pulmonary artery, and through the aortic wall and through the pulmonary walls. So cine imaging, along with the volumetric imaging, along with the quantification from phase contrast velocity images, will give us these kind of beautiful images in which we can exactly, reproducible, quantify the total amount of blood which is flowing through the aorta and flowing through the pulmonary arteries. Why it is so important for us to quantify the exact amount of blood flowing through. If we are able to quantify, we are able to quantify the exact amount of mitral regurgitations. We are able to quantify the exact amount of tricuspid regurgitations. We are able to quantify, most important thing, if there is a right to left or left to right shunting. If the blood flowing through the pulmonary arteries is more than the surrounding aorta, which should never be more than a 10%, it means there is an extra blood which is flowing through pulmonary arteries, and there is some kind of a shunting which is happening there. So all these images become very, very important. All these assessments become very important, and reporting a cardiac MRI without assessing the flow through these walls and through the aorta and pulmonary arteries is an incomplete study if we are doing it. So these are again the examples how the walls look like. Can you see this is a case of mitral stenosis? You can see the narrowed area of the mitral wall, and this is a case of, can you see the turbulence along the tricuspid wall? This is a case of tricuspid regurgitation. I'm sorry, I'm not able to show you the videos because it's going to take a lot of time, but this is how we can quantify and tell us about the So quantifying, we can at least tell that there's a mitral regurgitation and there's a tricuspid regurgitation, there's a mitral stenosis and a tricuspid regurgitation. And for quantification, we have to use the phase contrast velocity images and quantify how much is the total amount of blood which is going back to the previous chamber. So after adult imaging, the next important thing that is coming up in a big way is the pediatric imaging. If we only want an anatomical assessment of the various congenital anomalies of the heart, CT cardiac is the investigation of choice. Always remember, if you only want the anatomical assessment, because anatomical assessment with CT cardiac imaging is the best thing that we can do because of the less time, because we don't have to sedate the patient, beautiful ECG gating, and in and out the patient is out within 1 minute out of the cardiac. However, CT involves a lot of radiation. So if we are talking about a post-operative evaluation of a congenital heart disease, and we have to scan the patient again and again for evaluation of the congenital heart disease, and second most important thing about the functional assessment of the congenital heart disease, we have to depend upon the cardiac MRI. So cardiac MRI is good for congenital heart disease to accurately quantify the function and the volume. The PC flow for shunt fraction calculations is a very, very important tool for surgical diseases. Post-operative assessment of the patients for top complex congenital heart disease, fontan circulation coarctation, again, gives an edge of CMR over the cardiac CT. So I will just run this video to show you how a top patient underwent this cardiac MRI. And these are just the post-contrast plain axial images. And if I will stop the image, I'm sorry, and this particular is the graft that has been put in the right ventricular outlet to bypass the right ventricular outflow tract. There is now a dilatation of this graft size. If there is a dilatation eventually which will start, how much blood is flowing through it? How much is the right ventricle dilated? How much is the end diastolic volume and end systolic volume of the right ventricle will decide whether we need to reoperate this patient or we need to reoperate on this graft to bring down the size of this graft for not developing an Eisenmenger reaction and a congestion in the heart, and congestion in the lungs. This is another example in which we can beautifully see that there is an ASD. Along with this ASD, which is a left to right shunt, there is also an anomalous drainage of the pulmonary vein SVC. This vein is draining abnormally into SVC. So this is a partial anomalous venous drainage into the SVC through the left upper low pulmonary vein. Similarly, after talking about all this, we can also evaluate the mediastinal vascular structures. I will not go much in details. Anything related to aorta means aortic aneurysms, whether we're talking about the coarctation, whether we're talking about the dissection in AV malformations, everything can be assessed on CMRI as good as it can be assessed on cardiac CT, except for the timing, except for that in the young patients, we need to give the sedation. These are a few examples. This is a case of coarctation of aorta, and this is a case of multiple AV formations within the lung parenchyma, giving rise to shunting, which was only diagnosed when we scanned the entire lungs instead of just scanning the heart. So, take-home points and indications of CMRI. First is the coronary heart disease. Coronary artery disease is in which we have left ventricular dysfunction to assess the viability for further disease of a medical or a surgical surgical treatment for these patients. Chest pain with normal coronary artery angiogram to exclude myocardium. If there's a chest pain, we have a normal coronary artery angiogram. Always look for the myocardium, inflammation of the myocardium, which may be the reason for the myocarditis. Ischemia assessment in intermediate coronary artery disease, inducible ischemia and the viable tissue. Identification of scar site, ventricular functions, and anatomical abnormalities in arrhythmia evaluations. Further evaluation of characterization and extent of mass, various masses detected on echocardiography. Echo diagnosis of hypertrophic cardiomyopathy for disease severity and prognostic factors. First presentation of dilated cardiomyopathy. Complex congenital heart disease post-operative evaluation, especially in the patients of TOF. Evaluation and follow-up of coarctation of aorta and other aortic diseases like aneurysms and dissection, and follow-up and evaluation of valvular pathologies like vegetation, stenosis, regurgitations, and perivalvular. Thank you. I will end my talk here.
Thank you, Nidhi. It was an excellent and most beautiful images you showed. It was an excellent presentation, and I really enjoyed them so much. Maybe next time I'm going to come to your office and see the images for myself whenever I require the correlation of the arrhythmia with the cardiac MRI, of course.
I will definitely wait for you.
Yeah, it will be a pleasure. So in the interest of time, I have been told, Dr. Vinita, over to you. We'll not have question and answers, and we are already late by 15 minutes. Over to you, Dr. Vinita.
Yeah, thank you so much, Dr. Vanita Arora, Dr. Singhal, Ms. Angar, and Dr. Goyal for the greatly enriching lectures. It has been a really heavy learning session today, and I'm sure the audience have a lot to digest and also have a number of questions in their mind. Unfortunately, we have really exceeded our time, so probably we will skip the question and answer segment. If you have questions, then you can reach out to the speakers directly, and I'm sure they'll be happy to answer your questions. So don't be disheartened if we don't have the question and answer session here now. So to give the closing remarks, I would like to invite Mr. Selva Kumar. He is the president of ISRT. Actually, it was supposed to be Mr. Suresh Malayat, the General Secretary of ISRT, but unfortunately, we are not able to. So Mr. Selva Kumar will be giving the remarks. Mr. Selva Kumar has done his radiotherapy technology course from the prestigious Christian Medical College and Hospital. He's associated with IGNU, Hamdard, Guru Gobind Singh University, and CMC as examiner, expert committee member, and advisor academic activities. And he has numerous papers, publications, and presentations at national and international level. He was awarded the Sumnasa Seva Award for active participation in education standards among technologists. Mr. Selva Kumar is the first Indian technologist to handle SRS, SRT, and dedicated stereotactic radiosurgery unit 600 SR in South Asia. So he has handled more than 1,000 stereotactic radiosurgery procedure and 800 stereotactic radiotherapy procedures. And for the past 10 years, he's leading the team of ISRT as national president. So now I invite Mr. Selva Kumar to give the closing remarks.
Namaste, everybody. Hope I am audible. Namaste. Good evening to all. It is my proud privilege moment to be a part of the historic event today of GAPIO and GARTIO International Lecture Series. Today, basically, our General Secretary and GARTIO person, Mr. Suresh Maharaj, is supposed to give the vote of thanks, but due to his mother's actually serious and yes, she is hospitalized and he is taking care of her and not able to present here. Today is one of the historic event. We are joining it with the GAPIO team with the GARTIO. And we are happy to be a part of this day. And today, this day is a Makara Sankranti. In Hindu calendar, it makes the sun moving towards the northern direction. And this day is one of the best day. The day time and the night time is equal time. This day, the cold season is going to complete and the warm season is going to start. In our GAPIO and GARTIO team also, we are starting towards a new journey with a warmer session. Thank you all for making this session a interesting one. On behalf of the GARTIO and ISRT, we are very much thankful for to Dr. Anupam Sibal sir, President of GAPIO and Group Director Indraprastha Apollo Hospitals, for giving us an opportunity to be here and share our knowledge and share with the great giants of GAPIO team. We are humbly very much thankful for the entire GAPIO team for giving us this chance to be here. And recently, sir came to know about ISRT and GARTIO initiatives and activities, and sir invited us to be a part of this team. And really, we are very much thankful for your humble invitation for us, and we are really grateful for giving us a chance at this event. And you shared your words during the welcome notes. In spite of your busy schedule, you came here and given this kind words. Thank you so much, sir. And Dr. Vanita Arora, madam, thank you for making this this event by sharing the sessions. You are so smoothly and with ease you moved that session. All the 3 sessions you made it very simple and without any disturbances. Thank you so much for your ma'am, and thank you Dr. Vanita Sharan ma'am for your moderated the session from the starting onwards till now, and we are very much thankful for you for from the first day onwards. You are being with us in each and every activities, shared each and every topics, each and every words, and without untired support. We are very much thankful, madam, because we are, whenever I am seeing your messages are coming, and before giving reply also, because sometimes in busy schedule of our technologies, we may sometimes miss to give the reply also, but you are continuously giving us all the inputs, and thank you so much, madam. And we are very much thankful for our Professor Paniselvan sir will giving a welcome address. He shared about all the information about our activities. And our sincere thanks to Dr. Singal, Professor Radiodiagnosis in PGI, on giving a cardiac MRI principle. Sir is so smooth talk. It's easy to understand all the points he given you very nicely. And Miss Ajimol and sir, yeah, budding technologies given a good paper on this. And as usual, Dr. Nidhi Goyal, we are a very fan of Dr. Nidhi, ma'am. She's we have for the past few years I am observing her in Apollo hospitals, and her lectures are really superb. And ma'am is given a lot of examples and how to will go ahead. and our sincere thanks to Dr. Diti Sagani ma'am for coordinating all these activities from our Apollo side and through GAPIO, and Dr. Sushil Jain for coordinating all the activities, and Mr. Dr. Jitendra Malik for his regular updates, modifications, communications. Regularly is updating, and each and every small corrections he is making immediately. And thank you, Dr. Jitendra Malik sir. And our sincere thanks to each and every one working for this event directly or indirectly to make it a grand success. On behalf of the GAPIO and ISRT, our sincere Sankranti wishes to all the members of GAPIO, GAPIO, ISRT and their family members. Have a great year ahead. Meet you all soon in another interesting, successful scientific sessions. Thank you all. Thank you, ma'am. Over to you.
Thank you so much. I think with this, we will close the session for today. And I'm sorry for taking it over and up.
No, it was a pleasure. It was.
Time.
Thank you. Thank you.
Bye.
Thank you, sir. Good night to all.
I would like to add points.
Can I end the session, ma'am?
Yeah,
Follow-
you can end it
Thank
now.
you.
Thank you.